People normally start by thanking the organizer for the invitation. I don't think I should do that to Rafaela, because when she stopped me in a hallway a couple of months ago saying, can you talk at this thing? I said, sure, no problem. I thought it was the usual talk. And then later on, I only discovered what she wanted me to talk about. And I said, I've never done anything like that. And it's complicated because, I mean, I have to try to make it simple enough that people that are not, that are here, that are patients like you, or people interested in the disease that are medically not fully trained, might think that this is something that can relate to, or people vice versa who are medically trained that, saying, oh, this is so boring. I studied it in medical school at Biochemistry 101, so I don't know what I'm doing here. So bear with me. It's a bit complicated for me as well. So I'm going to be talking about biomarkers, but what is actually a biomarker? You heard about it many, many times during this day and a half about biological markers and what they're used for. And again, I took it from the NIH biomarker definition working group, because go back almost 20 years ago. So it's a characteristic of it which it can be objectively measured and evaluated, and can be used to indicate either a normal biological process or a pathological process, or a response to a pharmacological treatment to a particular disease, essentially a therapeutic intervention. It does not just define one purpose. It could be more than that. Many endpoints can also be considered biomarkers, and we'll see some of them later. Commonly thought in terms of biological, tissue samples, imaging. There's lots of things that go in and, and can be called biomarkers, can be used in biomarkers. So it's a very complicated concept, all put into this simple, relatively simple word. And also, as you've heard many times during the past day and a half, there are very different ways to measure, from the technological point of view, to measure these things. Again, imaging, but also, you're looking at gene expression. You're looking at, something that's in a biological fluid, like the serum or blood. So you can use also proteomics and all sorts of technological approaches. So not an easy task. But why there is a need for a biological marker, a biomarker in autoinflammatory diseases? Well, autoinflammatory diseases are groups of very heterogeneous syndromes. For some of them, we know that gene expression define separate diseases, separate group. You heard about the interferon signature that you see in SAVI or Candle, or AGS, or the IL-1 signature associated with NOMID, and diseases like that. And so biomarkers actually are useful to define subclinical population. But they're also very, very important in the context of treatment, and when you're looking into trying new drugs, either through a clinical trial or even just, as a compassionate use in some cases, because, they're important to discriminate if it's better to go with a, for example, blocking anti-TNF or blocking TNF or versus blocking IL-1 or blocking IL-6 or vice versa, coming with a JAK inhibitor, or vice versa, using a drug that depletes a particular cell population. So all these are very, very critical questions which biomarkers are utilized in order to inform an educated approach. So what are the characteristics of an ideal biomarker? It has to be accurate and reliable, of course. It has to be relatively non-invasive, so patient needs to accept the fact that you need to take a sample or anyway access to their body in a certain way. It has to be rapid as much as you can. It can't wait for months to know if something is working, and the assay needs to be standardized, and especially it has to be sensitive, specific, and the values needs to be reproducible. So very, very critical. And how do you choose it? Well, I think that the most important point is that we need to learn as much as possible in terms of the science behind a biomarker, the science behind the choice of a particular biomarker for a particular setting, for a particular disease, but for a particular treatment. It has to be very, very solid. And also the feasibility should also be taken into account. As I said, how long does it take, or how much does it cost even to assess a particular biomarker? And one thing that, although I'm not a statistician, and actually I hate statistics, to be honest, I mean, that's the full disclosure here, the statistical property of a biomarker are very, very important. So what's the dynamic range we're looking into? The analysis method that we utilize is very, very important. It has to be a very solid analysis method. And of course, we need to take into account the variability and how to estimate the variability of a possible possible parameters. So all these needs to be taken into account when we choose what to use as a biomarker of a particular status or a particular treatment. In general, we can define two sorts of groups of biomarkers. So we have biochemical markers and also genetic markers. And you heard both of them again in the past day and a half. Biochemical markers is something that normally you measure in a body fluid, for example. And actually, those are good, but the levels tend to fluctuate in circulation. It could be dependent on many, many factors. And also sometimes we tend to use, 1 point or a couple of points to look at that particular status. So this reflects just the transient, might reflect just the transient exposure. Genetic markers, vice versa, are fixed. So they're a little bit more, solid from a certain point of view. They're normally not affected by confounding factors. On the other hand, it's gene expression, so that must mean that sometimes they don't reflect the activity of the protein or the metabolites of the protein. So again, both of these type of markers can be utilized, but they both have pros and cons. So what are the type of biomarkers that we normally look at? We have prognostic biomarkers, so depending on the treatment that you look, you can look different changes. We have predictive biomarkers, and I'll get to that in some examples in the end. We have pharmacodynamic biomarkers, that changes in the response to a particular therapeutic approach. And then we can use surrogate endpoint or surrogate biomarker, which is something that you can use to measure an activity, but without having to look at in particular one point. It's just try to figure out outguessing what we get from the particular treatment. So in the case of inflammation, what do we normally look? What is normally looked by the physician that sees patient? And again, this becomes a little bit simple maybe for the medically trained people in the room. But in general, we look at alteration in blood cell numbers and functions and properties, and I'll get into that in a second. You heard many, many times from the slides already about C-Reactive Protein or SAA, serum amyloid A, and then there's also fibrinogen, complement components that are also measured. These are all changes that happen during an inflammatory status that could be chronic, acute, depending on infection or not, like in our diseases that we are discussing in these couple of days. And then also what happens is that growth factors are released by cells, immune cells, but also non-immune cells. Then they stimulate the production of cells of the immune system. So there is an increase in leukocyte production because they are needed to clear up an inflammatory situation. There is an increase in platelet production. And there's activation of cells that come in and scavenge and pick up stuff like the macrophages. And then there is the release of one of my favorite molecules, cytokines, which is a group of these molecules that are involved in regulating the immune response, the communication between immune cells. So those are all the cellular and biochemical changes that happen during an inflammatory process. So this is what happens to the cells. Again, this is classical textbook. You open a textbook and of pathology, and you see that during the initiation of the inflammatory phase, there's edema, and then neutrophils are the first cells that come in, followed by monocytes and macrophages that kind of come up and clean up everything, and then eventually there is the resolution. So at the cellular level, this is normally what happened during the course of a few days. In the case of the acute phase protein, vice versa, the one that I mentioned before, the C-Reactive Protein, the serum amyloid A, this is what happens. So some of them actually are very, very rapid. CRP and SAA come up very, very quickly. In a matter of just few hours, their levels are increased dramatically. Okay, some of them takes a little bit longer. They're involved more in the resolution and the second phase of the inflammatory response, like fibrinogen and so on. But so again, this is a very old slide. I mean, it comes from a paper from 1987, but it's still pretty much relevant because that's actually what happened normally. And what are the biomarkers that we look at in the context of autoinflammation? And I took this slide from a very nice review that came out, well, now almost 4 years ago. And some of the molecules that I already mentioned and that we'll get into details are, for example, again, serum amyloid A, CRP, some of the cytokines like interleukin-1, interleukin 6, and so on. So these are all biomarkers that we are we're looking at in the context of an autoinflammatory disease. So let's go with a little bit of this list of these molecules that I mentioned. The acute phase reactant, the acute phase proteins. Normally they're serum constituents that increase because of the inflammatory situation. They're mostly produced by the liver. The liver is the biggest producer of this protein, is the major organ that helps in the inflammatory situation. And their function is to limit the negative effect of the inflammation, of course, and to help prepare tissues and in general to keep things smooth and under control. So in response to local injury, the cells like neutrophils that you heard yesterday from Mariana, but also others like granulocytes and macrophages secrete a number of molecules, including the cytokines that I just mentioned before, into the bloodstream. And then this is the whole process of the inflammatory response. So let's go a little bit, not one by one, but let's look at the major one that normally are looked at and that you heard about it because if you are a patient, you've seen, your CRP went up or something like that. So CRP, it's actually produced by the liver, as I said, it's listed here. And actually, it's a reflection of a production depending on cytokines. Interleukin-6 is actually the major driver of the production of CRP by the liver, although IL-1 and TNF-alpha also are involved in the production of CRP. And actually, the levels go up very, very quickly in a matter of 4 to 6 hours. And actually, there's a typo. They go up to 1,000-fold, not 100-fold. Sorry, I just realized that. The major role of CRP is actually to enhance the binding of lipoprotein, to complement for the uptake from the macrophages, deactivate the endothelial cells to express adhesion molecule, and so on. But from the point of view of the biomarkers, the fact that it can be measured rapidly, reliable, it's very cheap to measure, and it's actually semi-quantitative because it can help you look at what happens during the recovery status. And I will get to the examples toward the end of the presentation. Sorry, let me go back 1 second here. I think that one thing, the important point I would like to make is that when normal, in general, if CRP is low and it's within the normal limit, then we can kind of exclude that inflammation is present. The other molecule that you heard about it's serum amyloid A or SAA. Again, major protein secreted during the inflammatory response. They also can go up to 1,000-fold, and it's several roles, mostly involved in removing cholesterol-filled macrophages from the site of injury and so on. But I think the most important point in terms of SAA is that the overexpression caused by an excessive and a continuous and chronic inflammation results in excessive production of this protein, which essentially has damaging effect known as amyloidosis. And you heard about it, the amyloid deposition in the kidney, which eventually might lead to a damage of the organ. So very, very important. Oh, sorry, let me go back again. Like CRP, it's mainly regulated by IL-1, TNF, and IL-6. Again, so we're going back to the cytokines. And is regulated also at the transcriptional and post-transcriptional level. And then there is the physical characteristic, changes the physical characteristic for the cells, right? And that's what I had a little bit of a note before. And that's the other parameter that you keep hearing about, sedimentation rate, ESR. So what is ESR? In general, our red blood cells, the erythrocytes, can be, let fall through a column of plasma, and they settle down in a little while, and this is the sedimentation rate. And then when there is an inflammatory situation, then fibrinogen and immunoglobulin binds the erythrocyte, coat them, and then these erythrocytes fall a bit more quickly. It's actually a prognostic test. So this is measured by the distance in millimeter. Measure is an hour. Let them go down, and then you measure how much they fell. And actually, it can be used as a prognostic test to detect the presence, but also the severity of the disease, and also as a follow-up of the disease. Again, I'll show you some example towards the end. There's also some false reading here. I mean, there are possibilities in which the ESR is increased, but it doesn't have to be, it's not directly correlated to the inflammatory status. For example, in the case of cancer like myeloma, or actually it increases with age or menstruation. There's lots of other factors that can influence that, so that also needs to be taken into account. Others, of course, I could go on and on and on and talk about for an hour about all the molecules that we measure or they're normally measured in the case of an inflammation, but it would definitely become a laundry list. But just for your information, we also look at fibrinogen. We look at procalcitonin, which is actually very interesting because it's very, very rapidly, like CRP and SAA, comes up very, very quickly. So one of the acute phase response reactive proteins, if you want to call it. And then the complement, of course, which is this complex of proteins which are important to normally get rid of bacteria. They attach to bacteria, they induce eventually opsonization and lysis of the bacteria, but they also induce chemotaxis. And then alpha-1 antitrypsin, which you might have heard in the case, because when alpha-1 antitrypsin is missing, then the body can no longer block the effect of proteases like elastase, which eventually might end up having negative effect on the lung and lung damage. It's one of the possibilities that can happen in some of the disease that we have been hearing about in the last day. And then the cytokines, of course, I work on the side. This is my topic of research, but I couldn't really find a very nice cartoon of talking about cytokines. There are so many around, and and it's complicated. It was frustrating from my perspective. But here I just decided to use this list to show you the cytokines that you heard already, like IL-1, TNF, and IL-6. Those are all involved in the acute inflammation. And also there are the cytokines that are involved in chronic inflammation, like interferon gamma or IL-12 or IL-17, or important and involved into the activation of the immune cell, but also of the non-immune cells like the endothelial cells and so on. And just to give you an example of which is not exactly connected to autoinflammatory diseases, but in a certain way it is. So this is a cartoon that I took from a review that I wrote with a colleague years ago, in which we're looking at the cytokines in the context of the joint inflammation. This is RA, but you can see there are many cell types that you heard about it, the macrophages, the dendritic cells from Virginia Pasquale today, and so on, the B cells and the neutrophils that Mariana talked about yesterday. But all these little boxes here, they're all cytokines. So they're really at the center of the inflammatory response, and that's why we measure them, okay? On the other hand, measuring cytokine per se can be useful and can be totally useless, and to be honest. And I do this, as a job almost day in, day out. But, full disclosure, sometimes can be useful, sometimes can be not. Then there are novel biomarkers or biomarkers that people are still looking into that and see, can these eventually be turned into real biomarkers? Can these be useful? Don't forget what I said at the beginning, the science behind it, it's critical. It's very, very important. So I think this is still in the process of being validated as scientifically valid. But you heard, yesterday Mariana talking about NETs or neutrophils extracellular traps, which is an indication of cell death of the neutrophils. But then neutrophils activation results in the secretion of calprotectin, for example, which is another, serum reactants that can be measured. You heard yesterday Dr. Kash talking about aldolase in the case of adult Still disease, and he also mentioned the HES100 family of proteins, which are also looked, and it was in my cartoon that I showed you before from the review from 2015. And then there are other cytokines. You will hear Scott about talking more about IL-18. Actually, you already talked about that today, IL-37. And then I put an other, and other are, for example, things that are just coming up, like exosomes, circulating DNA, all sorts of things that for even just a few years ago we had no idea they even existed, but now we know we can measure them. All we need to do is that, can we do it in a reliable way? Can we turn this into a scientifically solid test that can be applied to follow a disease or to follow the response to a particular therapy? So let me give you quickly some examples taken from something that we have been working on or others have been working on. So for example, you've seen this slide yesterday presented by Dr. Laxter. This is the work that we did in collaboration with Pearl Zhu and Ivona and Dan. And what my group in particular was tasked at the time was to measure cytokines. That's what we do in the serum and also in stimulated PBMC. And that what we notice is that, especially in the case of stimulated PBMC, you can really measure IL-1 beta in the serum. So there is an increase of IL-1 beta production and TNF in the stimulated PBMC from this patient when you treat them with LPS in vitro. And so this actually suggested the possibility that there could be an interventional for these patients. And in fact, when Armando Ombrello treated the patients with anakinra, which is an IL-1 blocker, you can see, I mean, the patient responded, and I think the clinical data were shown yesterday. But also you can look at two biomarkers that I mentioned before, the sedimentation rate and the CRP, going down with an increased dose of anakinra. So showing that we have kind of, pointed the fingers toward two possible molecules that could be targeted from the therapeutic point of view, and that can be used to eventually look at other biomarkers of response. So treating these patients, a patient with mutation in A20 with IL-1 beta or TNF inhibitors is actually something that works, and some patients even benefited from JAK inhibitors. Another example, again, taken from something that Raffaella presented yesterday, and we were involved in that as well. Looking, for example, at the Candle and the Savi patient treated with the JAK inhibitor baricitinib. And in this case, what I have here is the CRP, the protein that I mentioned before, which are very, very elevated in the Candle, and then upon treatment with the JAK inhibitors, they decrease. But also another biomarker is a cytokine. Actually, it's a chemokine, but it's the same thing. It's just a different kind of cytokine, IP10, which goes down, and it's a biomarker of response, in this case, a pharmacodynamic biomarker. And when baricitinib is reached at the optimal dose, you can see the level of IP10 going down. So great biomarker in terms of pharmacodynamic. Another pharmacodynamic biomarker that I decided to show you is actually a slide that was presented by Dan, and this is the work from Armando Ombrello here at the NIH. And these are the patients with the DADA2 mutation that you heard about. And so, again, looking at CRP and ESR, when you treat this DADA2 patient with anti-TNF, you can clearly see the C-reactive protein going down, and so is the ESR. Platelets also decrease, something that is also looked. I didn't have time to go into the details. So as I can see, trying to get towards the end of my presentation here is flashing red. So there are also some surrogate biomarkers. This is something that we've done recently in collaboration with Mariana Kaplan and Sarfraz Hasni. In this case, we were testing a JAK inhibitors in patients with lupus, so we actually had to figure out if they were actually engaging the target. So we were actually blocking the JAKs. We can really measure the JAKs very easily, so we decided to look downstream. Instead of looking at the JAKs, we look at the STATs, which are the transcription factor downstream of the pathway down in the context of the cytokine interferon signaling. And we'll look at the blocking of STAT phosphorylation, which happens after the JAKs are activated. And as you can see, patients taking the drug, the level of phosphorylation of STAT, in this case is STAT3, it's decreased. And then when you stop taking the drug, the level of phosphorylation go up. This is more of a surrogate biomarker that we use to look at target engagement rather than effect. And the final slide that I have is actually it's taken actually from a paper that I discovered very interesting, talking about familial Mediterranean fever. And this Japanese group in which, again, look at, as I said before, just measuring one cytokine or two cytokines sometimes can be informative. It helped a little bit, at least with the A20, but sometimes it can be totally misleading and will tell you anything. But in this case, a combination, or essentially try to combine the levels of different cytokines one with the other, might end up giving you the specificity and the sensitivity and the accuracy that can be used potentially, again, needs to be validated as a biomarker of response. In this case, some of the cytokines go down, but I think what I want to draw your attention here is that in some cases you need to look at more than one just to make sure that you have something that it can be considered, quote unquote, a biomarker. And I think this is my last slide, so I'll pass it on to Scott as the next speaker.